I'm Scott Allen. I'm the CEO of the Family Medicine Education Consortium. And if you don't know who we are a 14-state and DC regional coalition of family medicine training programs and medical schools. We serve the northeast corner of the United States. And we are holding these hot topics so that medical students and others who are interested can get to know some of the residency programs in the area. We have a big annual meeting coming up next week. Hopefully some of you will be joining us for that. And if not, the next one will be in October of 2023 in Providence, Rhode Island. So we're excited to have people join. I hope we get some more people on, and really thank Geisinger and Dr. Woloski and Sunu for joining us tonight and giving us a little talk about their program and some specific topics. So take it away, I guess.
All right. Dr. Woloski, do you want to start?
Sure. Well, welcome everyone. I see some familiar faces and some new faces, and it's always great to spend some time with everyone tonight. So we're from the Geisinger Northeast program, which is in northeastern Pennsylvania. We cover the Wilkes-Barre, Scranton area, and we're excited to be here tonight and share a little bit about our program, and especially one of the things that we love to do, which is outpatient procedures. So that being said, moving on to the next slide. Just a little bit about myself. So I'm actually the current president of the Pennsylvania Academy of Family Physicians. So I had my term start this last April. So it's been fun to kind of connect with a lot of the programs around the state. And Pennsylvania is very blessed that we have, you know, close to 50 programs residency-wise for family medicine. So it really is an awesome state to practice family medicine and be a family medicine doc. Obviously, my time at Geisinger has been wonderful. And in addition to supervising the procedure clinic, I still do outpatient and inpatient, and I still cover the football games on the weekends, and I still love to keep that broad scope. So I'm going to also take the privilege of introducing one of my excellent third-year residents on the next slide here. So Dr. Sunu, he's been stellar with our program, and I'm excited to have him kind of co-present with me tonight. Dr. Sunu is also involved with the Pennsylvania Academy of Family Physicians, serving on one of the committees of professional development. He also mentors some of the medical students at the Geisinger Commonwealth School of Medicine, very active in the community. He only mentions, you know, one of the activities that he's been active on, which is Walk with a Future Doc. And in addition to some sports medicine interest, he's great at teaching me all the epic tools that I need for my practice. Next slide. So just a little bit more about our program before we dive into some of the fun stuff that we're going to talk about tonight in terms of outpatient procedures. But we are a 666 program, so we have 18 residents. We've been around since 2007, and we were really excited that in June 2020, the system actually built us a brand new residency clinic. So we have all 18 residents under one roof, care manager, MTM pharmacist, a hospital across the street, which is a community hospital that we get to admit all of our patients to and keep a service there. And it's just a really, really fun place to practice. In addition to the weekly didactics, we have unique tracks in addiction medicine and Spanish track, and also our procedure clinic, which we're going to dive into a little bit tonight. So, as I mentioned, in addition to the weekly didactics that are filled with specialty lectures, M&M conferences, you know, we like to also add simulation a lot to the didactics, because if you have good simulation, then when you actually do these procedures on real patients, it's a lot of fun. And you can see one of my residents recently, I guess, had some fun with a pumpkin in terms of shave biopsies and punch biopsies. But it's really cool to just be able to simulate some of these procedures before you actually, you know, dive in and do these procedures on patients. And all of our residents do get Nexplanon certification and IUD certification through the manufacturers, in addition to simulation for joint injections, suturing, some dermatologic procedures like you'll see, and some of the other ones we're going to talk about tonight. This is just a link to our Instagram page. If you're Instagram follower and you want to pop on, and we'll, especially with interview season right around the corner, we'd love to stay connected and show you some of the fun and awesome things we're doing in our space. Next slide. So just to start it off, might sound like common sense, but what is the first step for any procedure? So the answer is A, consent. And you might say, okay, well, yeah, I knew that, but you'd be surprised when you're in a busy clinic and patient shows up 20 minutes late and you're like, oh my gosh, I got to hurry up and do this injection or something. How easy it can be to forget to get informed or consent from a patient. So just always remember that as one of your priorities. And I think that's one of the things we always stress is that, you know, it's important for patients to know what are the risks and benefits of every procedure, because not every procedure comes without risks. And as fun it is to keep a broad scope and do these procedures, it's important that patients have a good understanding of the procedure itself before we do it. Next slide.
Hello, can you hear me? Okay, so I'm going to be talking about some MSK injections. Just give a brief talk about steroids, the shoulder, the elbow, trigger fingers, hips, and knees. So this next slide is basically just to show you there's different types of steroids in the clinic. So it really depends what clinic you're at, in which regards what concoction you'll use. We usually use the solumedrol, decadron. And then this other one's basically showing, you know, there's different concoctions, basically all attendings use, but there's certain ones that are actually meant for certain joints as well. This next one, so this is actually one of our residents actually, and that's Dr. Woloski showing them how to do a shoulder injection. Basically the equipment you need is some gloves, some alcohol swabs, and ethyl chloride spray, which is basically like a topical anesthetic, and a 1/2 inch 22 gauge needle. And the cocktail we use in our clinic is a 4 cc 1% lidocaine without epi, and Canalog and a band-aid as well. So basically in this case we were just asking, just want to make it a little more active, like what kind of approach do you think it is? So this is specifically for a subchromial injection. I'll give you guys a couple of seconds to think about it. The answer basically is like a posterior approach. So we basically find the chromium, then we kind of find the far edge of it, the lateral edge, then kind of go inferior. And then when you do inject, it's more of a upward approach to the chromium as well. There is some people do blinded glenohumeral joint injections still, but kind of with the advent of ultrasound, it's kind of more people are using the ultrasound in that regards rather than blinding with the glenohumeral joint. But still a lot of people still do blinded subacromial joint injections. Next one is basically what is the indication for a lateral elbow injection. And basically, you know, A, golfer's elbow, B, tennis elbow, C, trochanteric bursa, or D, the carpal tunnel. The correct answer would actually be B for the tennis elbow. So if you actually can see in that picture right there, what we do is we basically find the lateral olecranon process right there. And once we find that, we find the point of maximal tenderness, and then we just kind of inject into a star-shaped pattern in that regards. This was basically just an alternate approach because there are people that do differently. So basically this is just a different way to do it. Then trigger finger injections. This is kind of important thing to know, like what kind of anesthetic do you use when you do a trigger finger injection? And then basically in this picture on this side is basically showing how you would do it. You basically, if you can see at the bottom, the B portion, you find the palmar crease, and then actually you can inject it a little below that, and you kind of find where the flexor sheath is in that regards. The answer to this question is actually you want to do it without epi, because there's a chance of actually vasoconstriction and you can lose, you know, possibly digits. So you want to make sure you're worried that you don't use it for your nose, your fingers, your toes, and also the penile region as well, because you don't want to lose any of those. Next one is a hip injection. What we have here is basically which bursa are we injecting. I actually blacked it out just so you guys can try and think about it. But right here, I'll give it away. You're looking at the greater trochanter and you find the point of the maximal tenderness. And once you find the point of maximal tenderness, you basically go in and you inject it. Sometimes you have larger set patients, so you won't actually be able to feel like the trochanteric itself, but that's okay as long as you're in that region. So a knee injection right here, this is one of our other residents as well here, just kind of learning for a lateral knee injection. The question we have in this case is, it's, you know, a 60-year-old female. She has a history of severe tricarpamental arthritis, returned a week after getting a right knee injection for a left knee injection, as she's never felt better. How long after her first one can she get a second one? I believe this slide is not updated completely because the answer for this would have been not 6 weeks, but it's actually more, it's basically undecided, because there's a lot of basically people who say that, you know, you can get a knee injection basically the same day, the day after. It's basically, there's no consensus made in that regards. Oh, and in regards to the consensus, it really matters though in regards to your patient specifically, because if they're an uncontrolled diabetic, we don't want to continuously give steroids in that regards. So it's just something to keep in mind. Next one, so we have dermatological procedures, shave versus punch, and the histofreeze and small sebaceous cyst or abscess in INDs. So if anybody knows, like, when should you do a shave versus a punch biopsy? Basically, the one to do a shave biopsy is if there's any chance of malignancy, we want to do a shave over a punch, because then there's a chance that, you know, we're not going to get the whole thing and it's going to spread, and then it's just going to cause a huge mess. Right here at the top is actually a shave biopsy. And the reason why I put this in the picture is because the first couple of times I did it, I was very, very scared basically of creating like a huge crater, because they always tell you that. But then I learned that you kind of have to take portion of the epidermis layer off. So you really got to bend the razor right there, and you got to get like a good chunk as well. But you got to get a good chunk, but you also got to make sure you don't really take that whole thing off as well. On the bottom picture right there is basically a punch biopsy, and you would do anesthetic for both of these. And basically you just move it in and you kind of twist it around, and then you just lift it up. And then if there is a portion of it still present there, that's like still attached, you just kind of take some scissors and cut it out. And then you always want to make sure that when you do take any of these samples, that you collect it, put them in the specimen container, and make sure you label not only have a label, but also label the specimen container in case, you know, anything gets lost, because you never know what's going to happen. Next one is just a histofreeze. So this is usually you can use for like paring down of warts or skin tags. Here's actually another one of our residents just practicing histofreeze as well. So it's basically you kind of let it out a little, you let the tip kind of freeze, and then you kind of place it on that wart or the skin tag you want to take off. The next one is a sebaceous cyst. Basically, what is a common attribute of a sebaceous cyst? I feel like this was an appropriate question, because whenever we precept in procedure clinic and we go out and talk to our attending, they always ask, like, so is it a sebaceous cyst or not, and how do you know? So the answer to this one is actually a central punctate lesion would give you the indication. So basically, if you take a look at the cyst, there should be like a little circle that's different than the rest of it, and that will let you know it's a sebaceous cyst. It's always important to measure it, take a picture of it like before and after as well. So then they're injecting the lidocaine, and when you inject it, you kind of want to raise it to the surface. and then you get the scalpel, you cut it into the central punctate, and you try and get the whole sac out. But I don't know how many of you watched Dr. Pimple Popper, but sometimes it doesn't always come out the whole sac. So you actually have to do dissection as well and kind of take out as much as you can if you're not able to get the whole sac. And then you just kind of squeeze it out as what you're seeing in one of the pictures down there. And then hopefully if the size is large enough, then you would have to do a suture, but hopefully not. In that case, you could probably get away with just maybe doing some silver nitrate or just kind of pushing some gauze and adhesing it that way. Next one. Next one is about gynecological procedures, and Dr. Woloski is going to kind of talk to you more about these.
Yeah, so great. Well, thank you, Dr. Sunu, for kind of the whirlwind tour there through some of the dermatologic and musculoskeletal ones we do. As all of you hopefully can see so far, just of everything that Dr. Sunu went through, there's tons of opportunities for outpatient procedures in primary care. And I often joke with my residents, I say, if you really say to me, oh, I wish I could be doing more procedures, I say, are you looking at your patients? Because I guarantee you someone has a mole that needs to come off. I guarantee you someone has a wart they want pared down. I guarantee you someone has, you know, a potential gynecologic procedure that you could help them with. So I think it's really, really satisfying when you can keep the patient within the medical home and offer all these procedures without always referring them out. So obviously within the world of family medicine, you know, there are a lot of gynecologic procedure variations in terms of what people offer in clinic and not. Currently, our clinic, we do not offer colposcopy, but we do Nexplanons, IUDs, endometrial biopsies, and the sorts. So those are some of the ones that I'm going to touch on tonight as part of this presentation. So Nexplanons, if all of you aren't familiar, it's a subdermal implant that is a great way for a long-acting contraception for a female. And the nice thing is, you know, you don't have to worry about a pill every day. It goes in your arm, and you're looking at 3 years of contraception. So as I mentioned earlier, Nexplanon training is something we provide to all of our residents and through the manufacturer so that they get formal training. Obviously, tonight I just wanted to walk you through a general overview of the procedure, obviously not meant to replace any type of formal training, but you know, putting the Nexplanons in is not actually a very complicated process. One of the first things you have to do, though, is ensure that you know, your patient is not pregnant. There's no chance of pregnancy. And then, as you can see in that first picture, kind of finding your landmark. So your insertion site is going to be, you know, probably about 8 centimeters or so from the medial epicondyle. And then you put your target site, which the Nexplanon is about 4 centimeters in length. So after you mark it up, next slide. In addition to cleaning the area, you know, and then you anesthetize with some lidocaine so that the patient, you know, should not feel a ton during the procedure. The Nexplanon comes in these great applicators. So you can see in that first picture, you basically release the cap from the applicator, and the Nexplanon's already stuck inside that needle and everything and ready to go. And then using your insertion site and your guiding mark, you kind of go in at a 30-degree angle and insert that needle, and then kind of guide it all the way through until that needle is hub. And then you pull down on the slider and boom, it just automatically releases that Nexplanon right under the skin there. And you are basically done with the procedure. I don't have slides on the actual removal of Nexplanons, but sometimes anecdotally, those are much harder than the insertion in the sense that you try to only make a really tiny incision to get it out of the arm. So sometimes you're fishing, or you're really trying to you know, release some of that tissue that may have developed over the Nexplanon over the 3 years when you're trying to get it out. But they're fun and they're a great satisfier for patients, and especially patients who are looking for a longer acting contraception option. it's great to be able to offer those. Next slide. So here's a question in here. It says, what is the most important steps prior to IUD insertion? I'll let everyone kind of take a look at the options there. Obtain a pregnancy HCG test, prior authorization, obtain gonorrhea and chlamydia, or really document the last state of unprotected intercourse. And so the answer is actually that all of these are the most important steps prior to IUD. So an IUD is much longer form of contraception. It's a little bit more invasive as well, since you are inserting the intrauterine device into the uterus. And so it's very important that there's absolutely no chance that the patient is pregnant. And so really, if there's any chance that this could be an early pregnancy missed on a urine HCG, or that there's been some concerns of unprotected intercourse, within the last week or 2 weeks or so, you should be very hesitant to offer this to a patient until you're absolutely certain that there's no chance of pregnancy. The good news about prior authorization is a lot of the Pennsylvania Medicaid plans and even the private insurers are now covering these, basically now mostly without prior authorizations. It was a little bit of a hassle in the years past, but it's a great patient satisfier and usually covered, 100% by the insurance company. As far as gonorrhea and chlamydia testing goes, even the data around that has changed in terms of you can actually offer it the day of insertion. And a lot of that has changed since we don't want it to be a barrier for women to have to come earlier first to get gonorrhea and chlamydia screening and then try to come back for an IUD and then potentially miss the next appointment, and you're repeating some of these things. So you can actually collect gonorrhea and chlamydia the day of insertion. And then if it was in any case positive, you can treat it even after the IUD is inserted. So as you can see on this slide, once again, the idea of tonight is not to go through entirely the whole process of an IUD insertion. But that picture on your left, you can see how many of these IUDs come. And the challenge mostly is, the workup to actually get to the point of inserting the IUD. So you do all those things listed on the slide, and then you have to cleanse the cervix, and you have to make sure you could get through the os, and sometimes you have to dilate the os, and then you have to sound in terms of measuring the depth of the uterus. And sometimes that takes a while and it can be difficult, especially depending on patient body habitus. But once you're ready to go, you basically can put the measurement that you need by moving that little marker there that you see at the top of the IUD. And then once you insert it, a lot of it has to do with just loading the IUD and then pushing back on the marker on the actual device, and then ultimately cutting the string. So it's once again, the nice thing about IUDs is a lot of the copper IUDs, which are non-hormonal, can be in there for about 10 years. And then you have a lot of the hormonal ones, especially the Mirena, which has every year seems to be gaining how long you can keep it in. So, I think now, it's upwards of 7 years almost that you can keep the Mirena device in, which is a great thing for women who have no plans of pregnancy in the near future. This next slide is just showing a brief simulation of endometrial biopsy, showing the uterus in the model. And the way we do it is we use the endometrial pipelle, which is plastic, and it kind of creates a vacuum suction to actually kind of pull some of that endometrial lining into the pipelle sample, and then sending it to the pathologist. The thing about endometrial biopsies is that they tend to be rather uncomfortable for patients. You should really advise them to take some ibuprofen and things like that before the procedure. but you are able to do that in the office without, any type of sedation or anything like that. And especially, women who may be following you for their routine PAPs and gynecologic exams and things like that. It's great to be able to offer that to your patients who may need it for various reasons without needing to send them out to a specialist. One of my most fun things to do are also ingrown toenail removals. Dr. Suno will probably laugh because the residents don't always like to do them, but they are quite satisfying when you can get that nail really that's lodged in there and be able to pull it out. A lot of times what we can do is actually just do a partial nail removal and keep some of the nail still on there for the patient. But the key to this is that you really got to anesthetize the toe properly because they are kind of a little bit gruesome in sense of, really breaking down that nail that's kind of lodged in there and kind of cutting it and pulling it out. So if you do proper anesthesia with lidocaine of the toe and really give it time to kick in, it's usually not too bad for the patient. Toes do like to bleed a lot, and like Dr. Sunu said earlier in the presentation, you can't use epinephrine for a toe because of your risk of ischemia. So depending on how you do it, some providers may put a little tourniquet around the toe. I tend to do it without a tourniquet just because I'm always very nervous about, risking ischemia. But that just shows you a couple pictures about the way to kind of remove the toenail.
All right. So the next one is basically as in like a surprise. This is actually a patient that I brought to Dr. Olaski, who was very excited after I told him what happened. So this is basically a mystery procedure. I'll give you a little background. This patient basically had an ATV accident about I would say 6 months before they came into the office, and they came in and they told us that they could hear a rattle when they moved their tongue across their teeth. So basically what happened is this was actually a tooth that got dislodged into the tongue. So that was basically the mystery procedure. Basically this was a procedure that, because then I saw them as a patient, they were okay with us basically taking out the tooth, and Dr. Woloski was there to precept and basically was there to basically let me do that by my whole self. And that was the first time I did it, and apparently that was very exciting to him, so we wanted to put it into this slide as well. And in case you want to know how big the tooth was, I did actually measure it afterwards as well. So that's actually the tooth. I would say it was about 5 millimeters that was actually stuck in there. So next slide is basically just saying, the end is just the beginning. So this is the end of the slide, but we hope that we do see you in the future, and kind of just wanted to give you a little, insight into our program as well. We're in the Northeast Pennsylvania. Some of those pictures are actually in our clinic and of our clinic. And then, one of the things that I found out that we're most known for is sweet sauce pizza. And then if you take a look onto I think it's left to right for you guys, basically that's each class, like the class that was graduating, there was a picture of everybody, then the third years from last year, then it's a mix, and then there's a one for every, I think that was class, basically third year, second years, first years from last year. And then that's my class at the very end as well. So that's basically the end of the presentation. Does anyone have any questions that we can take?
And it's a small group on here tonight, so feel free. I mean, there's no right or wrong questions. It doesn't have to be procedural based. We're happy to talk about our program, or I think, Scott, we have some time for questioning, correct?
Yeah, plenty of time. And I see Raphael has his hand up, so you can either put your hand up or just unmute and speak.
Um, Hello, thank you, Dr. Woloski and Dr. Suno for this presentation. It was very nice to see all the procedures that the programs perform. So I would want to know what are the common fellowships that residents use to choice, because I see that it's a program that is based on OB procedures and some procedures related to sport medicine. And I would want to know, do you perform point of care ultrasound training? Thanks.
Yeah, great question. So you know, we are very proud of training our residents very broadly so that whatever they want to do within family medicine, the door is open. We've had graduates become hospitalists. We've had graduates join faculties. We've had graduates go on to fellowship training. We seem to always have one or two with a sports med interest, or also you know, interest in addiction medicine, because we do also sponsor an addiction medicine fellowship in addition to the sports medicine fellowship at Geisinger. But the nice thing is, you know, you would leave our program and really feel comfortable no matter where you saw your career going. To answer your question about, you know, point of care ultrasound, I know it's a hot topic for everyone kind of on the interview trail. I guess, you know, I don't consider myself too old, but I consider myself old enough that I like to do a lot of these things without relying on the ultrasound. But we do have plans to slowly start implementing ultrasound. We don't currently have a formal curriculum within our family medicine clinic itself. However, our residents do get quite I would say a decent exposure to point of care ultrasound through their various rotations. So at Geisinger, almost all the ER docs are using point of care ultrasound. So the residents rotating through will, you know, get a lot of exposure to ultrasound on their ER rotation. You know, with the sports medicine fellowship, all of their sports medicine rotations, there's ultrasound being done all the time. Through OB, you know, when they're doing deliveries, since we're unopposed on the OB floor and everything, you know, you're seeing a lot of ultrasounds, and especially also in OB continuity clinic and things like that. So I think a lot of the ultrasound training is there, and we look forward to, you know, hopefully bringing it inside the clinic a little bit more in the future. So thank you for that question. Dr. Suno, I don't know, anything you want to add to that?
I would say you definitely get a lot in sports, depending on like what your plans are. If you tell them that you want to do a fellowship, they probably let you do a little more. OB, they definitely had me basically do a lot of ultrasound as like kind of a preliminary, then they come and check as well. The ED docs are all very, very nice. I'm not sure how it is other places, but if you really want to like do a procedure, you want to do ultrasound, they're always willing to as well. So I've never had an issue with like, I felt like, you know, if I needed to find an ED doctor and I was like, I'm interested in doing this on, you know, one of our inpatient patients, can you come and help me do it? And they're always willing to do it. That's about the only thing I would add.
Thank you.
Hi, I'm Mia. I'm also a Wilkes-Barre native, so I'm glad you gave a shout out to our pizza. I had a question about the procedures. So in terms of like increasing autonomy for residents with the procedures, how does that work? Is it usually by like year of residency or like numbers on each procedure?
I think I can answer that question. Basically, as like when you're in procedure clinic with Dr. Woloski, he basically just lets you do it the whole thing. There was a couple times I looked over and I was wondering if he would like stop me at the time and help, but he was just like, "You're doing fine, keep on going." So it's pretty much autonomous, as in as soon as they like procedure clinic as a first year, he pretty much lets you do as much as you feel comfortable with. The only thing I would say is that you would probably want an attending there with you for the procedure. The only thing I would say that you wouldn't need is a pap smear, but then you would definitely need a chaperone if you do it. But the other procedures, you most likely want someone to supervise you. I think one time I did a knee injection and they basically asked if I wanted to, if it was an outside attending, and they asked if I needed any supervision, and I said no, I was okay, and they let me do it as well. So it really just depends who you're precepting with. But to answer your question in regards to autonomy and procedure clinic, Dr. Woloski will just let you do the whole thing.
But I think at the same point, like Dr. Sunu said, within everyone's comfort level. So, and I think that's why we really stress simulation as well, because if you could master simulation, it's pretty close to a real patient encounter. So, the last thing we want you to do is go into a procedure and feel uncomfortable or feel like that you're improperly trained for it. So I think that's why the simulation is so important as well when we're talking about procedures. And the other nice thing is, as our residents kind of hone in on a lot of their procedure skills, it helps them as they go through other rotations as well. So for example, you get in the habit of, doing really well for punch and shave biopsies. When you go on your derm rotation, guess what? The dermatologists are going to realize your comfort level and let you do more. So I think the earlier you get exposed to procedures and the earlier you are able to do them, it's going to just really help your autonomy when you go through other rotations as a family medicine resident as well. Thanks for the question.
Yeah, and thanks for answering.
Hi, I'm Alexa. I'm a fourth-year medical student at LECOM, and so I'm from the Western New York area. So I guess I just wanted to know a little bit more about the area, any fun activities to do, that type of thing.
Dr. Woloski, you want to take this one?
Yeah, so I mean, thank you for the question. Thank you for joining us tonight. So yeah, I Northeastern PA is, I mean, of course, I always admit my bias with the area, but it really, really is a fun place to work. And I think one of the things I always tell applicants that one of the things we can't show you on a slide or we can't show you, always written is that family medicine is held in a very, very high regard in our area. And when, I have done some training in major cities and things like that. And sometimes, the demand for specialists and the demand to, see the top so-and-so for everything kind of, can be a little bit frustrating if you're trying to practice broad scope. But, I think the coolest thing about Northeastern PA is that they want you to do it. When we say to our patient, hey, do you want us to do that knee injection for you? They're like, oh yes, that's great. Can we do it now? And so, I think also Geisinger is very purposeful about giving their family docs a lot of resources to do the things we like to do. It's great that I have a case manager, a social worker, a behaviorist, and everything right in the clinic, that I'm practicing to really help with that. But to speak to outside of medicine, we're kind of in this really cool hub where we're 2 hours in one direction to Philly and 2.5 hours in the other direction to New York City. So a lot of our residents, will spend, weekend, going to the city, whether it's Philly or New York. There's a great bus system that offers good rates and things that you don't even have to drive. I think there's a lot of nature. You could probably be at a state park in any direction in probably 20 to 25 minutes. So we tend to have a lot of residents who enjoy outdoor activities, kayaking, hiking, those kind of things. We are home to a lot of actual minor league affiliates for sports. So when we talk about sports, we have the AAA affiliate for the New York Yankees baseball team. We have the affiliate for the Pittsburgh Penguins. So that's really cool if you're a hockey or a baseball person. Like Sean mentioned earlier, we have probably a pizza shop on every corner. So it's always fun to do that as well. So, on our website, I think we have a link to this very neat website also called Discover NEPA. And it actually takes you through a video tour of Northeastern Pennsylvania and everything, and really explains more. It's a great way to kind of get a feel of the community.
Thank you. That was really helpful.
And I know many of you are probably also doing application cycle this fall. So if you have any questions about that or anything we could do to help you, I mean, we're here, we're on, and feel free to ask away.
In terms of applications, I would want to know something. I was seeing something that at the beginning of the presentation that you put on a Spanish track. Could you speak a little bit about it?
So yeah, so over the years we've had residents with different interests, and one of the things we started offering were tracks, in the sense that they're not required. You don't have to do a track or anything like that. But say you came in and you said, I have some Spanish experience, but I would like to be fluent. And my goal is that when I finish residency, I want to be able to, sit for the certification to become a certified medical interpreter, so that I have, free reign to do that with my patients. The track is designed for individuals who aren't yet 100% fluent, but they work with one of our Spanish providers to really, hone in on those skills over the 3 years. And same thing with the addiction medicine track, with the fellowship, and actually several faculty who are graduates of our program now being faculty of that program. It's a great way to kind of connect earlier on, but by no means you could still do an addiction medicine fellowship without having done the track. You can still pursue your interests without doing the track in many different ways. But those are the two we currently have, just to kind of guide some interest for residents who may be interested. Anything to add, Dr. Sunas, to that?
So I know the current resident in the Spanish track. Well, actually, we have two, and we had one that graduated last year, actually. And they do actually have some Spanish knowledge before they came in, and they actually spend, from what I heard, they spend like about a half day in clinic in the actual Spanish clinic. And the preceptor himself just wants everything in Spanish. So you go see the Spanish, you talk to them in Spanish, you go precept with them in Spanish. I think the only thing that's not in Spanish is the notes, is what I heard. Otherwise, everything in Spanish. They get pretty comfortable with Spanish that I've seen, and they can even, like, if it's something minor, we may ask them, can you just help us talk to our patient a little? But we usually use a translator as well. And the goal for them is basically to end up, getting that certification and not having to use a translator out when they practice.
That's a good point. I mean, we really have a very diverse population we take care of, but our clinic does have two video interpreter devices. So, it's not as great as having an interpreter in person, but, the video interpretation and all the languages available, really do make, your clinic much, I guess, run much smoother than sometimes even if you just had to do the telephone.
Thank you.
Sure. Any other questions?
I had another question about, I guess when you work at like the continuity clinic, when you start out as an intern versus like a third year, how many patients are you seeing per day?
So our interns, we start them with 1 hour appointments, which is, it seems like a long time, but when you're getting to know the clinic, you're getting to know the EMR, you're getting to know, the patients, you're learning how to put in orders. It actually goes pretty fast. But, and then after 6 months, we move our first years to 40 minutes. And then it's kind of a slow progression after that. A lot of the second years have 30-minute appointment slots. And then once you get to your third year, you're looking at 40 minutes for new patients and patients over 65, and 20 minutes for acute, and those under 65. So we do it as a nice gradual progression. But just
very nice gradual progression.
Yeah, and we're very proud of, we really, there's different models out there, but we really are adamant that these patients become your patients. So, you know, even from day one, you know, the intern's name goes on the header bar. When they call with a message, it goes to the intern. When they send a MyG email, which is our portal system, you know, it goes to you. So, you know, that does become your panel, your patients, obviously with good oversight and attending there when you need them. But it's really fun training to, you know, July 1st, hit the ground running, which many of you will do next year, with some patients already ready to go for you.
I think the only thing added would be just to put that into perspective. So if it's an hour visit, you would see about 4 patients in the afternoon, as opposed to when you're a third year, 20-minute visits. I think if you had only 20-minute visits, I think it's a total of 12, and that's what I saw this morning, I believe. But then again, like you said, if you have new patients, and I think hospital discharges or over people over 65, then it would be 40 minutes. So you get a little longer time to really talk to them and make sure that you kind of address everything.
All right. Well, thank you all for taking time out of your busy schedules. I know, you know, other things you could be doing at 8 o'clock at night on a Thursday, but for those of you that are 4th years, you know, good luck with the application cycle, and we look forward to maybe seeing some of your applications come through. You know, if you think of anything after this presentation or want to get in contact with us, you know, feel free through our residency website or any other means. We're happy to connect with you. And I wish you all best of luck in your careers, and I'm excited to see such great people going into family medicine.